Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of having on the podcast Dr. Mariana Scaranti from Hospital 9 de Julho, Américas Oncologia, São Paulo, Brazil. We're going to be speaking about a publication in our journal titled ESMO 2025 Highlights, Top Studies in Gynecologic Oncology. Mariana, it's such a great pleasure to seeing you and having you on the podcast. Really, again, thank you for your time, for accepting our invitation. Really excited to talk about this manuscript with you.
Thank you, Pedro, for having me on the podcast. In a time when Congress updates are moving fast and the volume of information is overwhelming, meeting summaries are an excellent way to highlight what truly matters for clinical practice.
Excellent. Yes, I completely agree with you. And I encourage our readers not just to read this manuscript, but one of the things that I was mentioning to you previous to the podcast is that you really have been submitting high quality manuscripts to the journal. So I really, really appreciate it. So I encourage everyone to read anything written by Mariana Scaranti. So with that, we'll start with our questions. And I wanted to start first talking about first line ovarian cancer treatment. The ICON 8B revisits the dose dense chemotherapy. Tell us why this study was evaluated. Could you tell us how dose dense was first investigated in gynecologic oncology, and why is this still a debated topic today?
Great question. So, ICON 8B is a phase 3 trial in high risk stage 3 and 4 ovarian cancer that asked a very specific question. If we keep carboplatin every 3 weeks and add bevacizumab, the switch in paclitaxel to a weekly dose dense schedule improve outcomes compared with the standard 3 weekly paclitaxel schedule. Here, patients received up to 6 cycles of chemotherapy with bevacizumab continued as planned. And in the final overall survival analysis, median OS improved by about 10 months, favoring the dose-dense arm. Historically, dose-dense paclitaxel entered gynecologic oncology through the Japanese JGOG 3016 trial, which reported improved survival with weekly paclitaxel plus 3 weekly carboplatin compared with the conventional 3 weekly regimen. But when the strategy was tested in Western populations, results were mixed. GOG 262 was a negative trial overall, and any signal suggesting benefit from dose-dense paclitaxel appeared confined to the patients not receiving bevacizumab, highlighting that regimen interactions may matter. Also, ICON 8 did not show an overall survival advantage in a predominantly European population, and that's why it remains debated. The efficacy signal has varied by population and by companion therapies. The schedule has real trade-offs in toxicities and logistics. And now we are also layering in maintenance strategies. So the quick question becomes who benefits most and how we integrate this into today's treatment scenario.
So now, as a follow-up question to that, should the results of ICON 8B change practice today? Why or why not?
I would be cautious about calling ICON 8B immediately practice changing for everyone. Yes, the OS signal is compelling. Median OS of 49 versus 39 months with a hazard ratio of 0.79 with dose dense weekly paclitaxel on top of 3 weekly regimen in this high risk population. But there are several reasons to interpret this in context. First, it is a pre-PARP era trial in many ways. So recruitment ran from 2015 to 2020, and only about half of patients had germline BRCA sequencing, with no full HRD certification in the primary report. The investigators themselves highlight that more work is needed to understand whether benefit is impacted by HRD and chemosensitivity. Also, standards of care also evolved during follow-up. Today, frontline management is heavily shaped by biomarker-driven maintenance with PARP inhibitors, and ICON 8B does not reflect that contemporary pathway, raising the risk that differences in downstream maintenance access could confound overall survival data. Also, I need to say that one arm was discontinued after ICON 8 results, which is understandable, but it reinforces that this was conducted in a moving landscape. And last but not least, integration questions remain. We still don't know the best way to sequence or combine a dose-dense backbone with modern maintenance. And in practice, there is also a concern about hematologic toxicity, especially anemia, potentially affecting the ability to start and to stay on a PARP inhibitor afterwards. So in 2026, I would frame ICON 8B as a strong option to consider in selected high-risk patients, particularly where bevacizumab is already planned or where PARP eligibility access is uncertain, but I would not switch across the board until we have fuller publication details, subgroup data by HRD and BRCA, and a clear picture of subsequent therapies in the maintenance area.
Excellent. So with that, and you did mention the importance of PARPs. The next question is, how does the lack of molecular stratification in PARP use impact how we interpret this study?
Absolutely. And this is where the missing molecular data really matters. So HRD is both prognostic and predictive. It is prognostic because HRD positive tumors generally have a different natural history and platinum sensitivity. And it's predictive because HRD is the key biomarker that helps us to identify who is most likely to benefit from PARP inhibitor maintenance. So ICON 8B does not comprehensively capture HRD, and if PARP use after frontline therapy was not standardized, it becomes difficult to separate how much of the overall survival signal reflects the chemotherapy schedule itself versus differences in underlying tumor biology and access to the most effective maintenance strategy for HRD patients. That's why these gaps limit how we confidently generalize these results to today's biomarker-driven era. So I don't think we can apply that data in clinical practice right now without stratifying HRD here.
Mhm. So, Mariana, let's move over to maintenance treatment. The Duo-O NGOT OV46 GOG 3025 trial, durvalumab plus paclitaxel carboplatin plus bevacizumab, followed by durvalumab, bevacizumab plus olaparib maintenance in patients with newly diagnosed non-BRCA mutated advanced ovarian cancer, the final overall survival. The question is, moving to maintenance therapy now, talking about the results of this study, it showed impressive progression-free survival gains, but no overall survival benefit. How should we as clinicians interpret this?
Great question. Clinically, I interpret Duo as having a strong PFS signal, but not a practice-changing OS story, at least not yet. On the one hand, the triplet approach, chemo plus Bev and Durva upfront, then maintenance with Bev, Durva, and Ola, really delivers a clear and durable PFS benefit. And the most striking signal is in the HRD positive BRCA wild type group, with a median PFS of roughly 45 months with the triplet versus 33 months in 23 months in the control arm. So we are talking about nearly a 2-year improvement and a substantial reduction in the risk of progression. However, overall survival has not separated in the current analysis with a hazard ratio of 0.92 in the non-BRCA intention to treat population. So we should interpret Duo as a meaningful PFS benefit without confirmed survival advantage yet, because it's about 56 follow-up, 56 months of median follow-up and approximately 53 OS maturity. And there is a key design issue for the interpretation in 2026 because the control arm did not include PARP inhibitor maintenance. It was bevacizumab alone, so Duo can't clearly answer the question we really care about now. Does adding immunotherapy improve outcomes beyond contemporary PARP-based maintenance? What is telling is that when you take olaparib out, the durvalumab arm look less impressive than the full triplet. So it really seems like a big chunk of the PFS gain is being driven by the PARP component, not necessarily by added immunotherapy value. So I would present Duo as a meaningful disease control data, but insufficient to change the current standard without a PARP-inclusive comparator and more mature survival and patient-centered outcomes.
There's a follow-up to that as we're talking about immunotherapy. With multiple frontline immunotherapy trials giving us mixed signals, are we learning more about who not to treat rather than who to treat?
Great question. Yeah, I think we are learning at least as much about who we should not treat routinely as we are about who to treat. If you look across the frontline ovarian trials, the most consistent message is this. Overall, immunotherapy does not have a clearly defined role in the frontline setting. Take first, for example, both arms had a very contemporary maintenance backbone with niraparib, and when you add dostarlimab, you do see a statistically significant signal, but it is clinically modest with only about 1.4-month PFS gain. And there is no overall survival advantage. So when effective maintenance is already in place, the incremental contribution of immunotherapy looks small for most patients. Now, on the other hand, Killing showed a bigger PFS improvement, but the comparison is tricky because it's pembrolizumab-based therapy followed by olaparib maintenance versus chemotherapy alone, meaning the control arm does not include PARP maintenance. So it's hard to isolate the true immunotherapy add-on effect. And Duo O has a similar challenge. Interpretation is complicated because the control arm was bevacizumab alone without PARP maintenance, which is not really aligned with how many of us practice it today. So my practical takeaway right now is frontline immunotherapy does not yet have a clearly defined biomarker selected role in ovarian cancer, and I would not adopt it broadly outside clinical trials. What we are learning is that in unselected patients, you may be adding toxicity, complexity, and cost for a benefit that can be quite marginal once modern maintenance is accounted for.
Yeah. So let's turn to platinum-resistant ovarian cancer, and of course, obviously, a patient population where it still remains very challenging in terms of good treatment options. So I want to talk about the Rosella trial, GOG 3073, NGOT OV72, APGOT OV10, relacorilant plus nab-paclitaxel in a subgroup of patients with platinum-resistant ovarian cancer previously exposed to a PARP inhibitor. Can you tell us a little bit about the study design and the results? Seems like Rosella suggests a benefit for relacorilant plus nab-paclitaxel even after PARP exposure. What do we do with these findings?
Great question. Rosella is a randomized open-label phase 3 trial in platinum-resistant ovarian cancer, enrolling 381 patients who had received up to 3 prior lines, including prior bevacizumab. And patients were randomized to receive relacorilant, a selective glucocorticoid receptor antagonist, plus nab-pacli or nab-pacli alone, with the primary endpoint being PFS. Looking at the overall population, the trial met its primary endpoint, median PFS of 6.5 versus 5.5 months, with a hazard ratio of 0.7. And overall survival is still not mature, but so far, there is a clinically meaningful signal with an absolute OS gain of about 5 months. What is especially relevant for today's practice is the pre-specified PARP exposed subgroup presented at ESMO 25, which made up about 60% of the trial. In that group, the benefit looked stronger, with a PFS of 7.4 for the combination versus 4.6 for nab-paclitaxel alone, with a hazard ratio of 0.6. OS is still not mature, but there was an absolute gain of about 4 months. Where does it fit clinically? In 2026, a large fraction of platinum-resistant patients are post-PARP, so this is a very real-world population. I see relacorilant and nab-paclitaxel as a promising chemo-based option, particularly for patients after PARP exposure, and especially when they are not candidates for biomarker-driven options, for example, where folate receptor alpha targeted therapy is not available or is not appropriate. At the same time, I would position it as an emerging option rather than an automatically new default because we still want mature OS, and practically it depends on regulatory access.
Yeah. So let's turn to Keynote B96, another important study that was presented at ESMO 2025. This is a study of pembrolizumab versus placebo plus weekly paclitaxel plus minus bevacizumab in platinum-resistant recurrent ovarian cancer. Keynote B96 is one of the first trials to show an overall survival benefit in immunotherapy in platinum-resistant disease. Could you just let us know a little bit more about the study, its design, and how convincing are these results?
Absolutely. B96 is a randomized double-blind phase 3 trial in platinum-resistant recurrent ovarian cancer built on a very practical backbone, weekly paclitaxel with bevacizumab allowed because of AURELIA trial. We know weekly pacli, especially with bev, is one of the most active standards in the setting. The trial enrolled 643 patients with ovarian cancer who had received one to two prior lines and progressed within 6 months of platinum. They were then randomized to pembrolizumab or placebo every 6 weeks, combined with weekly paclitaxel. Bevacizumab was optional, and the primary endpoint was PFS, tested first in the PD-L1 positive population and then in the intention to treat group. The results showed a statistically significant PFS benefit, modest in absolute terms, and what really drew attention was the OS signal in PD-L1 positive patients with a clinically meaningful improvement. Now, how convincing is it? I would say it's an important step because it is a well-conducted, double-blind trial on a real-world chemotherapy backbone, and an OS signal in platinum-resistant disease matters. But I would also admit I have some degree of discomfort because we had multiple immunotherapy programs in ovarian cancer, especially in earlier lines, with negative or mixed results over the years. So for me, Keynote B96 is encouraging, but it also reinforces the idea that immunotherapy is unlikely to be one size fits all strategy in ovarian cancer. Practically, I see this as a supporting pembrolizumab plus weekly paclitaxel with or without BEV as a new option, particularly for PD-L1 positive patients early in the platinum-resistant course, but I would still position it as a selected patient strategy. I would like to see the full overall survival data set and how it integrates into the rapidly evolving ADC landscape before calling it as a universal new standard. And a more practical point, the study hasn't been published yet as a full peer-reviewed manuscript. The data we are discussing now come from the ESMO presentation, plus subsequent summaries and company press release noting additional overall survival findings in the all-comer population. Until we have the full paper, I would frame Keynote B96 as a very promising new option, particularly for PD-L1 positive patients early in the platinum-resistant course, while keeping a healthy degree of caution about how broadly we apply it.
Yeah. So Mariana, a question about your day-to-day practice and particularly in this platinum-resistant ovarian cancer population. Now with mirvetuximab, relacorilant, with nab-paclitaxel, pembrolizumab, paclitaxel with or without bevacizumab, what do you do to choose the ideal treatment for this patient population?
That's a great question because in real life, this decision is less about the best regimen on the paper and more about biomarker access and toxicities. In Brazil, we currently don't have routine access to Keynote B96 regimen or to relacorilant, so my practical options are usually AURELIA-based chemotherapy plus or minus bevacizumab, mirvetuximab for folate receptor alpha high disease, and much more rarely, trastuzumab deruxtecan for truly HER2 IHC3 plus tumors. If the tumor is folate receptor alpha high, I tend to prioritize mirvetuximab because Mirasol showed an overall survival benefit versus chemotherapy with a favorable tox profile. For HER2 IHC3 plus, TDXD can be considered, but this is an uncommon phenotype in ovarian cancer, and the evidence comes mainly from a phase 2 basket studies, 40 patients in the cohort, and when there is no actionable biomarker at all or access is limited, I fall back on AURELIA type strategies, often weekly paclitaxel as the backbone, adding bevacizumab when appropriate, tailoring mainly by prior tox, marrow reserve, comorbidities, and the clinical need for response.
Yeah. So one last question on ovarian cancer. With antibody drug conjugates, like obviously mirvetuximab, folate receptor targeted agents emerging and quite a number of other ones, Is this space getting very, very crowded? Is that necessarily a bad thing and a good thing? What are your thoughts?
It's getting very crowded and fast. After mirvetuximab validated folate receptor alpha as a real target and showed an overall survival benefit in MIRASOL, it feels like ADC development in platinum-resistant ovarian cancer is exploding, with multiple targets and multiple folate receptor alpha programs moving in parallel. Two ESMO 25 examples really illustrate how competitive this space is becoming. So we have Rejoice Ovarian with RDXD, a CDH6 ADC. The dose optimization cohort included platinum-resistant ovarian cancer patients without requiring CDH6 selection, and the signal was striking. Overall response rate of approximately 50%, with responses seen across CDH6 expression levels, low, high, whatever. And we also had the Fontana trial with AZD 5335, a folate receptor alpha targeted ADC. The early dose optimization data showed meaningful activity even in lower folate receptor alpha expressors, with overall response rate of roughly 61% for folate receptor alpha high and 48% in folate receptor alpha low. And my bigger concern, exactly as you said, is that many of these new ADCs are converging on similar payload classes, especially top one inhibitor payloads and DXD-based platforms. That raises the practical questions of cross resistance. Um, Changing the target but keeping a very similar payload may not always translate into durable sequencing. We are already seeing translational and clinical signals in other tumors that top one pathway changes can drive resistance across top one payloads ADCs. So diversifying payload mechanisms may matter. So yes, this is a crowded and rapidly evolving space. The next challenge won't be do ADCs work? It'll be how to select, sequence, and mix target and payloads while managing overlapping toxicities.
Yes. So now let's turn to endometrial cancer. The ATTEND trial was also a highlight of the meeting. It confirmed overall survival benefit only in MMR deficient disease. Tell us a little bit about this study. What were the results? Does this solidify biomarker-driven treatment in endometrial cancer?
Sure. So ATTEND is a randomized double-blind phase 3 trial asking a straightforward question in advanced or recurrent endometrial cancer. Thus, adding the anti-PD-L1 antibody atezolizumab to standard carboplatin paclitaxel and then continuing atezo as maintenance improved outcomes compared with chemotherapy alone. In terms of results, the final update confirmed a progression-free survival benefit overall, but the magnitude was clearly driven by biology. PFS improved in the overall population, and the benefit was much more pronounced in the MMR deficient tumors, hazard ratio of about zero point 0.3. Where it becomes really clinically meaningful is overall survival. There was no statistically significant OS benefit in the overall population, but there was a clear OS benefit in the MMR deficient subgroup, with OS not reached in the atezo arm versus 32 months in the control arm. In contrast, MMR proficient disease showed no OS separation at all. So yes, this absolutely reinforces biomarker-driven treatment in endometrial cancer. The take-home message is that MMR status is predictive for benefit from checkpoint inhibition, and it should be assessed upfront. For DMMR and MSI high disease, the case for incorporating immunotherapy with first-line chemotherapy is very strong. For PMMR disease, however, the picture is different. Better biomarkers and better strategies for that group are needed.
Yeah. Part of the presentation on a 10 involved a multi-omic analysis. And I wanted to ask you, does the aneuploidy score analysis suggest some MMR deficient tumors don't benefit from immunotherapy? Why should this be important?
Great question. This is important because it reminds us that MMR deficient is not a single uniform immunotherapy sensitive group. ATTEND clearly shows that overall MMR deficient patients benefit from adding atezo, including an overall survival strong signal. But this multiomic work suggests there is a small subset of MMR deficient tumors with a high chromosomal instability captured by the whole exome sequencing aneuploidy score that appears to behave very differently. In a tent, that high aneuploidy subgroup was about 9% of MMRD cases. They had a more immunosuppressive microenvironment, less immune infiltration, more M2-like macrophages, worse prognosis, and seem to derive limited or no benefit at all from atezolizumab. So clinically, I think the value is really twofold. First, it helps to explain why some MMR deficient patients still do poorly, even though on paper they have the right biomarker. And second, it suggests a next layer biomarker that could eventually refine how we select patients, basically flagging who might need a different strategy or a clinical trial instead of assuming all MMR deficient tumors behave the same way.
Excellent. So, with that, do you see multi-omic profiling realistically entering routine clinical practice, or is it still at research level?
In the near term, I still see this as research level. I would be cautious about calling it ready for routine practice. In the autism arm, the MMRD high score subgroup was a very small subgroup for patients, so validation is required. The concept is very compelling, using multiomic feature to refine which MMR deficient tumors truly benefit from immunotherapy, but right now it is exploratory and hypothesis generating. Practically, whole exome sequencing and integrating multiomic profiling are not widely available as a standard of care. And even when they are technically feasible, we still need clear, clinically actionable cutoffs, assay harmonization, prospective validation, showing that changing treatment on these markers actually improve outcomes. In Brazil, where resources and access are more limited, I think incorporation into routine care will likely take even longer.
Yeah. So let's turn to cervical cancer. It's an interesting study that presented a chemo-free first-line option in cervical cancer, a phase 3 study of camrelizumab plus famitinib versus platinum-based chemotherapy as first-line therapy for recurrent or metastatic cervical cancer. Tell us a little bit more about the study design for that study and how practice changing is this?
Sure. This was a multi-center randomized phase 3 trial in recurrent or metastatic cervical cancer, comparing a chemo-free regimen, camrelizumab plus famitinib, against investigator choice platinum-based chemotherapy with paclitaxel with or without bevacizumab. After a median follow-up of approximately 20 months, the chemo-free combination significantly improved progression-free survival and also improved overall survival, so 34 versus 23 months with a hazard ratio of 0.65. Grade 3 related adverse events were quite prevalent, 87% in the IO arm and 67% with chemo. While these efficacy results are impressive and support the feasibility of chemo-free strategy, I'm cautious about calling it practice changing globally because the control arm did not include immunotherapy and only about 31% of the patients received bevacizumab. So it is not a clean comparison against today's chemo IO standards. And finally, this was conducted in East Asian population. I would like to see the validation in a more diverse and Western cohort before broadly extrapolating the magnitude of the benefit.
Yeah, so as I'm hearing, we should be cautious before considering even adopting this approach.
Of course, of course. W-
Now, I wanted to ask you one more question, and then we'll go to the final question. Um, you were at ESMO 2025 in Berlin. If you had to name one study or disease category from that meeting that most influenced your clinical decision making, your thinking, which one would it be and why?
If I had to pick one area that most influenced my clinical thinking, it would be platinum-resistant ovarian cancer because for the first time in many years, the space feels dynamic and increasingly option rich, we saw multiple signals pointing in different directions. So Rosella suggesting benefit with relacorilant plus nab-paclitaxel, including in patients previously exposed to PARP inhibition. Keynote B96 reporting an overall survival benefit with pembrolizumab added to weekly paclitaxel plus or minus bevacizumab, and then a wave of highly promising ADCs like RDXD with response rates around 50%, even in an early phase dose optimization setting. So what's changing, my thing, isn't just one drug. It is the realization that our biggest challenge now is shifting from what can I offer to how do I sequence these options wisely. These therapies were studied in different populations with different inclusion criteria. They come with very different toxicity profiles. In 2026, optimizing sequencing based on biomarkers, prior exposures, patient fitness, and tolerability may be just as important as the efficacy signal themselves.
So, Mariana, as a last question, now we have a tradition on the podcast that we ask a question formulated by AI after reading your manuscript. So the question from AI is, as antibody drug conjugates and biomarker agnostic strategies show striking response rates in platinum-resistant disease, are we approaching a point where traditional platinum sensitivity classifications are becoming biologically and clinically obsolete?
AI is great, absolutely. And a good example is Piccolo. Even in a platinum-sensitive population, rituximab delivered response rates that we would traditionally associate with more chemosensitive biology. So, in the single-arm phase 2 study of folate receptor alpha high recurrent platinum-sensitive ovarian cancer treated in third line or later, mirvetuximab achieved an overall response rate of roughly 52%. So when we see ADCs generating these kind of responses across different platinum categories, platinum resistant and platinum sensitive, it reinforces the idea that we are increasingly treating based on target expression and mechanism, not just on the platinum-free interval. Platinum sensitivity still has a prognostic value, but it is becoming less central to how we sequence our most active therapies.
Mariana, thank you so much for this really enlightening discussion. Again, I always learn so much from reading your manuscripts and of course, obviously, from the wealth of information that you offer. Really very impressive. Thank you for the work that you do, that you continue to do for our field, for our patients, and truly remarkable as a role model yourself as well. So really very honored to have shared with you this space in this podcast.
Thank you again for inviting me to join the podcast. It was a real pleasure and honor to participate. I truly appreciated the opportunity. Thank you so much.